Thank you so much for the opportunity to present at your meeting. My name is Ankeeta, and on behalf of my colleagues at the Coalition for Global Hepatitis Elimination, I will be presenting the results of our scoping review, looking at prevention, testing, and treatment interventions for hepatitis B and C in refugee populations. While our scoping review does look at interventions globally, I will point out the studies from the EU and EEA as they are available. Okay, these are our disclosures. So for background, refugees are heavily burdened by hepatitis B and C. Previous systematic reviews have shown that refugees who are residing in traditional immigrant receiving countries and who are from countries with intermediate to high HBV and HCV endemicities are at high risk for HBV and HCV. In low and middle income countries, refugees experience a higher prevalence of HBV than the general population, ranging up to 60.8% in some populations. Studies from within refugee camps have found an intermediate to high prevalence of HBV among refugees, and in some settings, a high prevalence of HCV as well. Despite this increased risk, refugees are still less likely to be screened and treated for HBV and HCV, face limited to no access to routine health care, and face linguistic, cultural, social, and insurance barriers to care that put them at a higher risk of late diagnosis in advanced HBV and HCV-related liver disease. Due to the high hepatitis burden and high barriers to care, our research question was, what are the available services for hepatitis for refugee populations, and what are the key features that address these barriers to care? The scoping review characterizes published experiences of HBV and HCV prevention, testing, and treatment interventions serving refugee populations to inform the development of improved services. Refugees is a term that's difficult to define, especially across countries, so for the purposes of this scoping review, we included any study that mentioned refugee, asylum seekers, or internally displaced persons in their study population. We identified 69 studies published in English between January 2010 to July 2022 through a literature search that was conducted on 3 databases, Embase, Cochrane, and PubMed. The keywords that we used in our literature search were related to HBV, HCV, education, screening, testing, treatment, vaccination, harm reduction, and refugees. In our scoping review, we included any study that described HBV or HCV prevention, screening, or treatment interventions for refugee populations with details about program implementation. Studies that were included in our review were categorized as prevalence, implementation, or economic modeling studies. Prevalence studies described systematic screening efforts that were undertaken to determine the disease burden in a specific population. Implementation studies described operational details of delivering prevention, testing, or treatment services for refugee populations. And economic modeling studies described the use of mathematical modeling to estimate the cost or cost effectiveness of potential interventions. Information about location, intervention type, outcomes, recruitment, program accessibility features, and challenges were extracted. Descriptive analysis was conducted on each group of studies, prevalence, implementation, and economic modeling studies separately. We classified 23 studies as prevalence studies, and of these, 10 were from countries in Europe. Germany and Italy had the most economic modeling studies out of the European countries. Italy had 4 economic modeling studies, and Germany had 2. While analyzing the prevalence data was not the main goal of our scoping review, we did briefly summarize the prevalence estimates that were provided by these studies. As you can see on the slide, the prevalence of hepatitis B surface antigen and the HCV antibody varied widely from low to no prevalence to as high as 23%. We classified 38 studies as implementation studies, and of these, 18 were from countries in Europe. The European countries included Finland, France, Germany, Greece, Italy, Norway, and the United Kingdom. The most common intervention setting was clinical settings, so 20 studies took place at clinics or hospitals. The second most common setting was multiple settings, so this meant that the study described an intervention that took place across multiple sites, for example, a combination of clinical sites and community centers or something like that. So of the 38 interventions, 11 were vertical HBV interventions, 2 were vertical HCV interventions, and 1 was a vertical HBV and HCV intervention. Often though, HBV and HCV services were integrated into a general infectious and helminthic disease screening or a general vaccination program. So 24 studies described HBV and HCV interventions that were integrated in this way. Interventions were classified in our scoping review by what components they had. These components included testing, referral to care, education, vaccination, treatment, and harm reduction. Interventions could have more than one of these components. So we found that testing was the most common component to be included, followed by referral to care. Vaccination and treatment were the least common component to be included, and there were no interventions that included a harm reduction component. So we found that there was limited reporting about program impact, and this included things like screening coverage, treatment outcomes, vaccination rates, and referral to care rates. Generally, screening acceptance was high among refugee populations. So we found that for HBV screening coverage, 7 out of 14 studies reported a screening coverage of over 75%. For HCV, 5 out of 7 studies reported a screening coverage of over 75%. Only 2 studies provided information about treatment outcomes, so treatment impact, conclusions about treatment impact can't really be made. Vaccination rates varied widely across the studies that provided them, and there were no explicit reports of hepatitis B birth dose coverage across these studies. So referral to care rates also varied widely as well, and they were primarily reported for HBV. For future evaluation and replication purposes, it could be beneficial for studies to consistently report outcome information moving forward. Interventions described in the scoping review address common healthcare barriers during the recruitment process by reaching patients through collaborating with partner organizations and visiting well-frequented community locations for recruitment. In order to recruit participants, programs commonly requested partner organizations to refer patients, involve community health workers, cultural mediators, community leaders, religious leaders, or social workers in the process, and utilized word of mouth. Recruitment was most commonly conducted during clinic or hospital visits or at refugee accommodations, apartment complexes, and camps. Interventions have also made progress in addressing language and culture, healthcare navigation, geographical barriers, and cost when it comes to service delivery. So 36 of the 38 implementation studies reported program features that were associated with healthcare accessibility. Community engagement was a key thread among frequently identified accessibility features regardless of country of origin. And in the table, I've also highlighted the features that were reported by European countries with 2 red asterisks. So in general, interventions commonly leverage partnerships with community stakeholders, organizations, and hospitals. They also employed members of the community that they were serving. Interventions incorporated language and culture of the community they were serving through providing bilingual services, education, care, and test result notifications, employing cultural mediators and other professionals to provide cultural and language support, and involving other cultural elements as appropriate, such as a prayer break and ethnic food during an education workshop. Some studies from European countries reported having accessible clinics for the refugees. So this meant that the clinics were located on site, or that refugees could go visit the clinic any day without appointment. Studies from European countries also reported offering hepatitis services free of charge to refugees, conducting screening immediately after the refugees' arrival or consent on site, and employing staff to serve as patient navigators throughout the monitoring and treatment period. One study mentioned utilizing in-house PCR systems that were previously used for the screening of soldiers for refugees. So in spite of all of this progress, continuity of care and transient still remains a challenge to delivery. 30 studies reported challenges, and some studies reported more than one challenge. Loss to follow-up after screening was most commonly reported among referral to care interventions, and difficulty completing or monitoring vaccination series was commonly reported among interventions with vaccination components. Additional challenges included language or communication barriers, the refugees' mobility, equipment supply and medicine limitations, as well as a lack of medical knowledge among the refugees. So now I would like to share an example of a vaccination campaign that was conducted to highlight lessons learned in delivering programs for refugees. So the PHILO's Emergency Health Response for Refugees Crisis in Greece was conducted for 1 year from April 27 to April 2018. It was led by the Greek Ministry of Health and the Hellenic Center for Disease Control and Prevention and was funded by the Asylum, Migration, and Integration Fund. Various vaccines were provided during this campaign, including the HBV vaccine, which resulted in HBV vaccination coverage of 48.6% for the first dose and 24.7% for the second dose. And these vaccines were provided for children aged 0 to 4 years old. So challenges that were identified by this program were related to staffing and the refugees' mobility. They reported an insufficient number of cultural mediators. They reported that refugees were residing in multiple areas, camps in the community, and that refugees were frequently entering and leaving various camps and community shelters. And this led to difficulty with monitoring vaccine coverage and delivering them. So the program addressed some of these challenges by being flexible and by working with a broad group of stakeholders. So first, vaccinations were conducted at a wide range of locations in order to ensure a broad reach. Vaccinations were conducted at camps on the mainland, at reception and identification centers, at community health centers, and in safe zones. Safe zones allowed for the reach of unaccompanied minors, and the other locations allowed for a broad inclusion of refugees. Staff members included community volunteers and camp members to support cultural mediation, and PHILO's also partnered with NGOs and other organizations in order to provide the vaccinations. Vaccination campaigns were also sometimes conducted for longer periods of time than originally intended in order to account for the changing populations and other unexpected needs. And finally, during the door-to-door visits that PHILO's conducted before the vaccine intervention, they assessed the vaccination status of children, provided education on the importance of vaccination, and also provided education on why it was important to store these vaccination records safely. They conducted these visits with the support of a cultural mediator when possible and provided written information in multiple languages. So in terms of funding, national level financial support does appear to be essential to hepatitis service delivery as seen by the 20 studies that reported funding sources. 12 studies reported receiving governmental support and 8 studies reported that refugees were included in the National Health Insurance Scheme. So we classified 8 studies as economic modeling studies and 1 was from a country in the EU. So overall, the results of these economic modeling studies are conclusive about which combinations of intervention types are the most cost-effective. This could be due to differences in the context of the intervention, such as different countries or settings. So the one economic modeling study that was from the European region, the one from Germany, found that the cost associated with HBV screening was the highest out of all of the other infectious diseases that refugees were being screened for in Germany. Additionally, the study found that the costs were lower with public health insurance versus private insurance, and this supports the cost benefits of including refugees in a public health insurance scheme. However, at the end of the day, additional economic analyses are needed to inform program planning going forward. In conclusion, this is the first scoping review to look at hepatitis prevention, screening, and treatment interventions targeting refugees. Across available studies, community stakeholder participation, governmental support, language services, and incorporation of culture appear to be key to hepatitis service delivery. Challenges include loss to follow-up, difficulty completing the HBV vaccination series, and the refugees' transients. So moving forward, additional services and data are needed. Additional data is needed to guide the delivery of vaccination, linkage to care, and treatment services for refugees. Current interventions have found that treatment and vaccination were the least common intervention components, and common challenges were related to these intervention types. More data would be useful to determine if separate interventions for refugee populations are effective or if integration into the host country health system would be more effective. So future interventions can be tailored to the language and culture of the refugee population, and there is a need to promote continuity of care for refugees in future interventions. It could be beneficial to explore methods to retain the refugees' health and contact information in the healthcare system, or to develop easier pathways for refugees to enter the healthcare system as possible ways to ensure continuity of care. Overall, it's important to share implementation logistics, outcomes, and lessons learned to expand access to hepatitis services for refugee populations. Cool. Thank you so much for listening to my presentation. If you have any questions, they can be sent to either me or Lindsay, and our emails are up on the screen. Thank you.